The Epic CVX, designed for cardiology, built for better care. Intuitive, user-friendly technology. A better patient experience with improved patient outcomes. Innovation and you, Philips.
We welcome all the readers for this e-textbook of echocardiography in congenital heart diseases. The first chapter will be dealing with segmental analysis of congenital heart diseases. By segmental analysis, we will be dividing the heart into manageable segments, analyze each of the segments, and formulate a comprehensive diagnosis. This will facilitate a complete understanding of even very complex cardiac defects. Segmental approach refers to dividing the cardiac analysis into three main cardiac segments. Each of them is independent of each other, and each of them may be variable. The segments can be concordant or discordant to each other. We should start with defining the visceroatrial situs and the cardiac position. Then look at the atrioventricular connections. This will be followed by assessment of ventricular morphology. Then we will look at ventriculo-arterial connection. And then finally look into the intracardiac and extracardiac abnormalities. As the abdominal viscera and the atrial situs are often concordant to each other, it's combinedly referred as visceroatrial situs. In situs solitus, which refers to the normal atrial arrangement, the morphological right atrium is on the right side and left atrium is on the left side. When we look at the abdomen, the inferior vena cava and the liver mass will be on the right side. The abdominal aorta and the stomach will be on the left side. In situs inversus, there will be a mirror imagery. So the liver and the inferior vena cava will be on the left. The abdominal aorta and stomach will be on the right. And the morphological right atrium will be on the left and left atrium will be on the right. Situs ambiguous can fall into the category of left isomerism or right isomerism. A subxiphoid view of a cross-section of abdomen will show that the aorta is lying on the left side and the inferior vena cava on the right side. In relation to the spine, the abdominal aorta will be a little bit more posterior to the plane of inferior vena cava. We can appreciate the entire liver mass on the right side and the stomach bubble on the left side. In situs inversus, there will be a mirror image of what we saw in situs solitus. Here, the abdominal aorta will be on the right side of the spine and inferior vena cava will be on the left side of the spine, and inferior vena cava will marginally be anterior. The liver mass will be noted on the left side and the stomach bubble will be noted on the right side. From the subxiphoid coronal sweep, as we make a superior tilt of the probe to image the heart, we can appreciate the position of the heart in the thorax. If the cardiac apex is going to point towards the left, it's defined as levocardia. If the cardiac apex is pointing towards the right, it's referred as dextrocardia. And if the cardiac apex is pointing downwards, then it's defined as mesocardia. On this subxiphoid coronal sweep, we can appreciate that the cardiac apex is pointing towards the left side of the thoracic cavity, so this will be levocardia. On the contrary, here we can appreciate that the cardiac apex is pointing towards the right side of the thoracic cavity, so this will be an example of dextrocardia. When the cardiac mass apex is pointing downwards towards the subxiphoid area, the heart is more or less in the middle, and this will be referred to as mesocardia. While it is very easy to recognize the abdominal structures like liver, inferior vena cava, which normally are found on the right side in situs solitus, the abdominal aorta and stomach, which are normally found on the left side in situs solitus, we need to have certain clues to identify and recognize the right and the left atrium. The methods through which we identify the right atrium and left atrium will be to identify the relationship of the inferior vena cava and abdominal aorta in the abdomen and see the opening of the inferior vena cava. In most hearts, the inferior vena cava will be opening towards the morphological right atrium. If we are able to appreciate the atrial appendages, we can appreciate the morphology of the atrial appendages. The flap valve of the oval foramen, the coronary sinus, will also help in identifying the right and the left atria. On this subxiphoid short axis view, we can appreciate the superior vena cava entering the right atrium. Immediately below the superior vena cava atrial junction, a large triangular appendage is seen protruding anteriorly. This is the right atrial appendage. The right atrial appendage is broad-based and is triangular in shape. On a parasternal short axis view, on the left side of the aortic root, we can appreciate the left atrial appendage. It's a finger-like in shape and has got a narrow base. But we need to understand that the size of the appendages may vary depending on the hemodynamics of the atrioventricular valve. So even a left atrial appendage will look very, very dilated if there is an associated left atrioventricular valve stenosis or severe regurgitation. And so atrial appendage morphology is difficult to categorize the atrial situs on echocardiography. Another morphological parameter used in differentiating the right atrium and left atrium will be to identify the limbus of fossa ovalis. The limbus of fossa ovalis, which refers to the ridge of the septum secundum, the caudal margin of septum secundum, always lies on the side of right atrium. In this subxiphoid short axis view, we appreciate the superior vena cava entering into the right atrium. The right atrium is seen on the left side of the screen. If you track the atrial septum from above, the protruding ridge of septum secundum can be seen pointing towards the right atrial side. This limbus of fossa ovalis will show where the morphological right atrium is. Immediately below the limbus of fossa ovalis is the floor of fossa ovalis. This floor of the fossa ovalis is formed by septum primum, which lies on the side of left atrium. So if we identify the limbus and the floor of fossa ovalis, we can say that the limbus will be on the side of right atrium and the floor of fossa ovalis will be on the side of left atrium. Another useful parameter for identifying the morphology of the atria will be to look at the coronary sinus. In this apical 4-chamber view, when we make a posterior tilt, as the mitral valve apparatus disappears, on the posterior mitral annular groove, we can identify a parallel echolucency which represents the coronary sinus. The coronary sinus lies in the floor of left atrium. So the position of coronary sinus will indicate the position of the morphological left atrium. Compared to these above mentioned differences between the two atria, namely identifying the atrial appendages, identifying the limbus of fossa ovalis and floor of fossa ovalis, identifying the coronary sinus, the more simpler method of identifying the atria will be to look at the inferior vena cava entry into the atrium. Inferior vena cava almost always enters into the right atrium. In this subxiphoid short axis view, we can appreciate the inferior vena cava entering an atria. This atria will be the morphological right atrium. While inferior vena cava entry into the right atrium is almost always consistent, superior vena cava drainage may be variable. In this example, we can find the large dilated right superior vena cava draining into the posterior morphological left atrium. So superior vena cava cannot be taken as a criteria for identifying the morphological right atria. We can appreciate the inferior vena cava draining normally into the right atrium. In the previous example, where the right superior vena cava was seen entering the left atrium, an injection of an agitated saline through the arm cubital vein shows that the saline contrast is entering from the superior vena cava into the morphological left atrium. So the drainage of superior vena cava cannot be taken as an indicator of atrial situs. Similarly, the drainage of left superior vena cava is also very variable. The left superior vena cava can drain through the coronary sinus into the morphological right atrium. In this example, we can see the long coronary sinus coursing through the floor of the left atrium and draining into the right atrium. However, in this example, we can see the left superior vena cava draining directly into the left atrium without any coronary sinus. There is a complete unroofing of the coronary sinus. So the drainage of right and left superior vena cava can be to either one of the morphological atria and hence should not be taken as an indicator of the position of right or left atrium. However, the inferior vena cava drainage is always towards the right atrium. The color Doppler from the suprasternal view shows the direct drainage of left superior vena cava to the roof of the left atrium. Like the superior vena cava, the pulmonary venous drainage is also variable. In patients with total anomalous or partial anomalous pulmonary venous drainage, many of the pulmonary veins may be draining directly onto the right side of the heart. So we cannot identify the atria as right or left depending on pulmonary venous drainage. In this example, on a subxiphoid coronal sweep, we can appreciate a TAPVC of all the 4 pulmonary veins draining through a common chamber onto the posterior wall of the right atrium, shown with an arrow. We can notice that the right atrial blood courses through the foramen ovale, shown with another arrow, towards the left atrium. In a small proportion of structurally abnormal hearts, we cannot identify a standard pattern of situs solitus or situs inversus. These will fall into the category of ambiguous situs. Ambiguous situs can be grouped under two heads, the left isomerism or the right isomerism. In left isomerism, which is also called as isomerism of bilateral atrial appendages, we will notice that both the atria have appendages which has got the morphology of a left atrial appendage. So there will be smoother pectinate muscles, and the pectinate muscles of the atrial appendages do not extend on to the atria. In almost all of the patients with left isomerism, the inferior vena cava will be interrupted and it will continue as azygos towards the superior vena cava. If there is a total anomalous pulmonary venous connection in patients with left isomerism, it is never extracardiac. It's always intracardiac. Subxiphoid short axis view shows the superior vena cava draining into the right atrium. We can appreciate a large azygos vein coursing in the posterior paravertebral gutter and turning anteriorly towards the superior vena cava and draining in the posterior wall of the superior vena cava. We can notice that there is no direct entry of the inferior vena cava into the right-sided atrium. With a color flow interrogation, we can notice the flows in the azygos, which is directed away from the probe and so takes a blue color. The azygos turns around anteriorly above the level of the right pulmonary artery, which will represent the right hilum of the lung, towards the posterior wall of right superior vena cava. The azygos drains the inferior vena caval blood into the right superior vena cava. Contrary to the previous condition, isomerism of left atrial appendages, the other ambiguous situs will be right isomerism. In this example, both the atrial appendages will have the morphology of right atrial appendage. There will be coarse pectinate muscles that will extend from the atrial appendage into the atria. In almost all these patients, the inferior vena cava and abdominal aorta will be on the same side of the spine. In all these patients, the coronary sinus will be absent. If there is a total anomalous pulmonary venous connection, it will always be extracardiac. Since most patients with right isomerism will also have asplenia, this is defined as asplenia syndrome. On a subxiphoid sagittal plane cut, we can appreciate the inferior vena cava and abdominal aorta on the same side. The inferior vena cava will directly be anterior to the abdominal aorta. This is a common feature in asplenia syndrome or right isomerism. On an axial cut from the subxiphoid view towards the abdominal structures, we can identify that the liver is in the midline. We can see the abdominal aorta and the inferior vena cava both on same side of the spine. The inferior vena cava is anterior and towards the transducer. The abdominal aorta, which has got the systolic flashing of red color, is posterior and away from the transducer. Right isomerism is characterized by absence of coronary sinus. We can appreciate a large left superior vena cava draining directly onto the roof of the morphological left-sided atria. This is commonly seen in patients with asplenia syndrome. After morphologically defining the visceral situs and the atrial situs, we then move on to the atrioventricular connection on segmental analysis. The atrioventricular connections can be concordant or discordant. When we say concordant atrioventricular connection, we mean the left atrium is connected to the left ventricle and right atrium is connected to the right ventricle, as in most normal hearts. Discordant atrioventricular connection will refer to left atrium getting connected to the morphological right ventricle through the tricuspid valve, and right atrium getting connected to the morphological left ventricle through the mitral valve. The way of identifying the mitral and the tricuspid valve on echocardiogram will be to look at the sign of offsetting, identify the septal trabeculations of the right ventricle, identify the caudal attachments of atrioventricular valve towards the interventricular septum, and identifying the two discrete papillary muscles which will be a hallmark of left ventricle. The first point in differentiating between right and the left ventricle will be to identify the smoother surface of one of the ventricle. We need to appreciate the smoother or the coarse nature of the trabeculae from the interventricular septum and not from the free wall of the ventricles. On this example, in the apical view, we are able to clearly appreciate the interventricular septum. We notice that the septum is smoother on the left hand of the screen and is more coarser on the right hand of the screen. So, the ventricle on the right hand of the screen will represent the morphological right ventricle, and the smoother portion on the left hand of the screen will indicate morphological left ventricle. When we do a three-dimensional echocardiogram, we will be able to appreciate the coarse and the smooth trabeculations of the heart far better. This is a subxiphoid view of the ventricular surface. We have cropped off the apical and mid portions of both the ventricles and looking at the basal portion of both the ventricles, we can notice that the ventricle on the left hand of the screen has got a very rough trabeculation and has got a ground glass appearance. The ventricle on the right side of the screen has got a smoother endocardial surface. So this will represent the smooth-walled left ventricle. We can appreciate the trabeculations better on three-dimensional echocardiogram. Another method of identifying the right and the left ventricle will be to look at the caudal attachment of the atrioventricular valve towards the interventricular septum. The mitral valve leaflets do not have any caudal attachment towards the interventricular septum. However, the tricuspid valve has got significant caudal attachments from its entire septal tricuspid leaflet towards the interventricular septum. So whenever there is a caudal attachment, that side will indicate the morphological right ventricle. In this example, we can appreciate the chordae from the atrioventricular valve seen on the left side of the screen getting attached towards the interventricular septum, and so that will represent the tricuspid valve and show the location of the right ventricle. In other words, tricuspid valve is septophilic, which means the chordae are directed towards the septum. Mitral valve is septophobic, that means the caudal apparatus are directed away from the septum. The sign of offsetting refers to the relative attachments of the mitral and tricuspid valves in the region of atrioventricular annulus. The mitral valve annulus is located a little bit more basally, and the tricuspid valve annulus is displaced a little bit more apically. So the atrioventricular valve, which has got attachments more apical, will represent the tricuspid valve, and the atrioventricular valve, which has got more basal attachment, will represent the mitral valve. Identification of two discrete large papillary muscles are also a feature of left ventricle. If we can clearly identify two good-sized trunks of papillary muscles, that ventricle will represent the morphological left ventricle. We need to understand that when the ventricle is very hypoplastic, the morphology of the ventricles will be difficult to be assessed by all these criteria. This is an example of an extreme hypoplasia of the right ventricle, and we will not be able to appreciate all the standard features. Similarly, in an extremely hypoplastic left ventricle, again we may not be able to appreciate the characteristic features of right and left ventricle. We found that the atrioventricular connections can be either concordant or discordant. In concordant atrioventricular connection, we mean the right atrium is connected to the morphological right ventricle through the tricuspid valve, and the left atrium is connected to the morphological left ventricle through the mitral valve. In discordant AV connection, it will refer to right atrium getting connected to the left ventricle and left atrium getting connected to the right ventricle. All these things will form the group of biventricular atrioventricular connections. There will be a small proportion of hearts which will have a univentricular connection. It can either be a double inlet left ventricle or right ventricle. It may be an absent right atrioventricular valve or an absent left atrioventricular valve. In biventricular connections, where there is atrioventricular concordance, we can notice the morphological left atrium getting connected to the left ventricle through the mitral valve. The mitral valve will be appreciated by its more basal attachment compared to the tricuspid valve, which will have more apical attachment, showing the offsetting. The mitral valve chordae will not have any attachment towards the interventricular septum, and so will be septophobic. The interventricular septal surface will be more smoother on the left ventricle, and the left ventricular cross section will show two good-sized papillary muscles. In discordant atrioventricular connection, the right atrium is connected to the morphological left ventricle. In this apical view, we can appreciate the valve on the left side of the screen is more basally attached, and the valve on the right side of the screen is more apically attached. Similarly, the ventricle, which is on the left side of the screen, has got more smoother surface on the interventricular surface and has more rough trabeculations on the other side. So this will represent the right atrium getting connected to the morphological left ventricle and the left atrium getting connected to the morphological right ventricle. We can also notice that the atrioventricular valve shown on the right hand of the screen has got a lot of attachment towards the interventricular septum. So this is a septophilic tricuspid valve. The other is a septophobic mitral valve. Atrioventricular discordance and atrioventricular concordance can be seen in both situs solitus and situs inversus. In this example, we can appreciate there is situs inversus and levocardia. There are two atria seen from this modified apical view. The atria on the left hand of the screen receives the pulmonary veins from both the sides. This patient had situs inversus, and so the atrial situs is also inversus. However, the atrioventricular connections, when we analyze, we find that the atrioventricular valve on the left hand of the screen has got more apical attachment. The AV valve has attachment towards the interventricular septum and has got features of the tricuspid valve. The AV valve on the right hand of the screen is septophobic and has got more basal attachment. So that represents the mitral valve. So in the setting of situs inversus, atrial situs inversus, there is an atrioventricular discordance. This will be called as isolated AV discordance or isolated ventricular inversion. In this patient, the pulmonary venous blood that is returning into the morphological left atrium, which is located in this particular example on the left hand of the screen, will be draining towards the right ventricle and so will lead to systemic desaturation. On a color flow imaging in this patient with situs inversus, levocardia and isolated atrioventricular discordance, we can see the pulmonary venous blood returning into the morphological left atrium, which is seen on the left hand of the screen, draining through the tricuspid valve into the morphological right ventricle and again getting recirculated into the pulmonary artery. So there is a parallel circulation which will cause a physiology similar to transposition of great arteries. Even though the right ventricle and pulmonary artery are properly connected, the left atrium is connected to right ventricle and hence it leads to a parallel circulation. This isolated AV discordance is also called as isolated ventricular inversion. So far we found that in biventricular connections, we can categorize the atrioventricular connections as either concordant or discordant. The atrioventricular connections can be concordant or discordant in either situs solitus or in situs inversus. Now we move on to univentricular connections. This is an example of double inlet ventricle. In this patient, we can find that there is double inlet, both the atrioventricular valves directed towards one common large single ventricle. When there are two atrioventricular valves which are draining into the same ventricle, we can appreciate the morphology of the two atrioventricular valves by carefully looking at the annular attachment of the AV valves. In this apical four-chamber view, we can notice that the valve that is seen on the left hand of the screen has got more basal attachment, and the valve that is seen on the right hand of the screen has got more apical attachment. So the valve on the left hand of the screen will represent the mitral valve, and the valve on the right hand of the screen will represent the tricuspid valve. So this is an example of AV discordance in the setting of double inlet ventricle. In univentricular AV connections, the other abnormality that can be seen is a common atrioventricular connection. Here we can appreciate a large common atrioventricular valve with a free-floating bridging leaflet. The common atrioventricular valve can be favoring the right ventricle, as in this example. We can notice a small rudimentary left ventricle. This will be an unbalanced AV canal with a common AV valve favoring the right ventricle. Sometimes the common AV valve can favor the left ventricle. This is an example of an unbalanced AV canal with common AV valve favoring the left ventricle, with the right ventricle being very hypoplastic. The common atrioventricular valve, which is connecting to one large single ventricle, can either be draining into single ventricle of left ventricular morphology or a single ventricle of right ventricular morphology. The differentiating feature will be the extremely coarse trabeculations of a right ventricle compared to a left ventricle. In the univentricular atrioventricular connections, we started seeing hearts which are having two atrioventricular valves. They can either be concordant atrioventricular valves or discordant atrioventricular valves. Then we moved on to see common atrioventricular valve. Sometimes one of the atrioventricular valve can be atretic. This is an example of right-sided atrioventricular valve being atretic, which is classically defined as tricuspid atresia. Sometimes the left-sided atrioventricular valve can be atretic. All these will represent univentricular atrioventricular connections. While analyzing the atrioventricular connection, we also need to understand two terms, the overriding and straddling. When the annular plane of one of the atrioventricular valve is overriding an inlet ventricular septal defect, then it is defined as override of the atrioventricular valve. In this example, we can appreciate that when we draw a line from the trabecular portion of the interventricular septum towards the atrioventricular annulus, it will commit the left-sided atrioventricular valve about 80% towards the ventricle seen on the right hand of the screen and about 20% towards the ventricle seen on the left hand of the screen. So this will be a 20% override of the left-sided atrioventricular valve, which in this patient is the morphological tricuspid valve, because the tricuspid valve has got septal attachments and also is more apically attached. So this is an example of straddling tricuspid valve with a large inlet ventricular septal defect. We can notice the caudal attachment of the tricuspid valve going on to the crest of the interventricular septum. Whenever there is an attachment of one of the AV valve chordae towards the crest of interventricular septum, it is called as grade 1 straddling. Grade 2 straddling will refer to attachment of the AV valve apparatus and the AV valve chordae towards the opposite side of the interventricular septum. Grade 3 straddling will refer to attachment of the AV valve chordae towards the free wall of the contralateral ventricle. In this apical four-chamber view, we can appreciate there is a large inlet ventricular septal defect and there is a 40% override of the tricuspid valve towards the left ventricle. If we draw a line from the interventricular septum towards the AV valve annulus, we can appreciate that 60% of the tricuspid annulus is committed towards the right ventricle and 40% of the tricuspid annulus is committed towards the left ventricle. So this will be defined as tricuspid valve override. We can also notice that there are a lot of chordae from the tricuspid valves which is going towards the free wall of the left ventricular cavity. So this will represent grade 3 straddling of the tricuspid valve or right atrioventricular valve. One of the rare variants of an atrioventricular connection will be called a crisscross AV connection. In this apical four-chamber view, we can appreciate that the left atrium is connected through an atrioventricular valve, but it directs the blood towards a right-sided ventricle. The course of the blood flow from the left atrium towards the ventricular mass on the right side is shown by arrows. With a color flow interrogation, we can notice that the blood flow is from the left atrium towards the ventricular mass that is seen on the right side. In the same apical view, on a further anterior sweep, we can notice that the right-sided atrium is allowing the blood to flow towards the left-sided ventricular mass. On a color flow imaging, we can appreciate the flow of blood from the right atrium towards this left-sided ventricular mass. The atrioventricular valve also has got a mild regurgitant jet. The blood flow direction is shown by arrow. So in this example, we can appreciate that there is a crisscrossing of the atrioventricular blood flow. The direction of flow of blood in the left AV valve and right AV valve are in opposite directions. In some of the abnormal hearts, the ventricular mass can be located in a superior and inferior planes. They will be referred to as upstairs, downstairs ventricles. In the subxiphoid coronal plane sweep, we can appreciate the morphological right ventricle located superiorly and the morphological left ventricle located inferiorly. On a subxiphoid short axis view, we can appreciate that one of the ventricular mass is located superiorly and the other ventricular mass is located inferiorly on the diaphragm, indicating a superior-inferior ventricular relationship or upstairs-downstairs ventricles. In segmental analysis, after describing the atrioventricular connection and the ventricular morphology, we move on to the ventriculo-arterial connection. This can be either concordant or discordant. When aorta is arising from the morphological left ventricle, it's defined as concordant VA connection. However, if the pulmonary artery is arising from the morphological left ventricle, this will be called as discordant VA connection. In this subxiphoid short axis view, we can appreciate the aorta arising from the morphological left ventricle as in most normal hearts. Similarly, the pulmonary artery is arising from the morphological right ventricle as in most normal hearts, and this will represent ventriculo-arterial concordance. In this parasternal long axis view, we can appreciate that the anterior right ventricle is giving off to the aorta and the posterior left ventricle is giving off to the pulmonary artery, leading to ventriculo-arterial discordance. This is the characteristic feature of transposition of great arteries. We can notice that both the great arteries are coursing parallel to each other. Sometimes, in the setting of ventriculo-arterial discordance, there can be coexistent atrioventricular discordance also, as in this example. Here there is an atrioventricular and ventriculo-arterial discordance, which will be referred to as the corrected transposition of great arteries or L transposition of great arteries. When we look at the great arteries, the method of identification of a great artery as aorta or pulmonary artery will be based on certain morphological features. Whenever a great artery is giving off the coronary arteries, the arch vessels, and is not having a proximal division, it will represent the aorta. If there is a proximal division into right and left-sided vessels, it will represent the pulmonary artery. Double outlet of right ventricle will represent another abnormality of ventriculo-arterial connection. In this parasternal long axis view, we appreciate that the ascending aorta is entirely coming off from the morphological anterior right ventricle. There is an aortomitral fibrous discontinuity. Such an origin of aorta from the right ventricle, if it is combined with pulmonary artery also arising from the right ventricle, will represent double outlet right ventricle. On this subxiphoid short axis sweep, we can appreciate both the great arteries arising from the right ventricle. So this is a classical example of double outlet right ventricle. There is a rare entity called anatomically corrected malposition of great arteries. Here, there is a normal atrioventricular concordance. In this transesophageal view, we can appreciate the right atrium getting connected to right ventricle through the tricuspid valve, left atrium connected to the left ventricle through the mitral valve. In the same patient, when we look at the right ventricular outflow tract towards the pulmonary artery, we can notice the presence of a small conal tissue. So there is a subpulmonary conus. Conus is a part of right ventricle and always separates the pulmonary artery away from the atrioventricular valves. There is no conus in a normal morphological left ventricle. In this left ventricular outflow visualization of the same patient, we can notice a normal left atrium to left ventricle connection through the mitral valve, but the aortic valve is separated from the mitral valve by a very long conal tissue. The presence of subaortic conus is a feature of anatomically corrected malposition of great arteries. In these patients, the blood flow will be normal from the pulmonary veins towards the left atrium, left ventricle, and subsequently into the aorta. However, because of the presence of a long subaortic conus, the aortic valve will get displaced anteriorly, thereby causing an anterior aorta and posterior pulmonary artery. So there is a malposition of the great artery, but internally it is anatomically corrected. So this is called anatomically corrected malposition of great arteries. While analyzing the ventriculo-arterial connection, we can identify in some of the hearts the two great arteries will have common origin. This will be referred to as truncus arteriosus. The two branch pulmonary arteries may arise together from a main pulmonary artery as in truncus arteriosus type 1, or the branch pulmonary arteries may arise separately from the trunk as in truncus arteriosus type 2 and 3. The other abnormalities of ventriculo-arterial connections will be an atretic aortic valve and atretic pulmonary valve. Subxiphoid short axis view shows a single great artery arising from both the ventricles. The great artery divides immediately into an ascending aorta which ascends superiorly and a main pulmonary artery which courses posteriorly. So this is a truncus arteriosus type 1. While discussing about truncus arteriosus, we need to appreciate that there is a condition called hemitruncus. In hemitruncus, one of the great arteries, aorta, gives off one branch pulmonary artery which can be either the right or the left. In this common example of a hemitruncus, we notice the right pulmonary artery arising from the posterior wall of the ascending aorta. The main pulmonary artery continues as the left pulmonary artery. One of the semilunar valves can be atretic. This is an example of aortic atresia. We can appreciate a hypoplastic left ventricle. The aortic valve is atretic and is closed. There is a small hypoplastic ascending aorta that is seen as a parallel structure in the middle of the screen. The anterior right ventricle and the pulmonary outflow tract are markedly dilated. Sometimes the pulmonary valve can be atretic. This is an example of a pulmonary valvar atresia shown on subxiphoid short axis view. We can notice that there is a continuous flow in the main pulmonary artery through the ductus arteriosus, and there is no antegrade flow from right ventricle towards the pulmonary artery. A detailed cardiac echo analysis will be ending up with analysis of the arch. The long axis view of the aortic arch will demonstrate all the three arch blood vessels. The first branch of the left aortic arch will be the right innominate artery, which will branch into right carotid and right subclavian. We can show the branching pattern of the first arch vessel with arrows in this suprasternal view. In patients with right aortic arch, the first branch will often be the left innominate artery. We can appreciate the right aortic arch on the right side of the tracheal rings. The tracheal rings are shown as white echogenic dots. In this frame, we can appreciate that the aortic arch is located on the left hand of the screen. The first arch vessel branch from this right arch is the left innominate artery. If we trace the left innominate artery further down, we will appreciate that it branches into left carotid and left subclavian arteries. Whenever the first arch vessel branch doesn't branch out into two vessels, we need to think that the subclavian artery may be arising as a last branch and having an aberrant retroesophageal course. In this example of right aortic arch, we can notice that the first branch is non-dividing. This will represent the left carotid artery. There is a parallel another systolic flow in another blood vessel, which will represent the aberrant retroesophageal left subclavian artery. In some hearts, the aortic arch can be doubled. This is an example of a double aortic arch. On a suprasternal coronal plane sweep, we can appreciate the ascending aorta branching into two arches, which goes on either side of the trachea and fall back towards the midline. This is a characteristic feature of double aortic arch. Arch of the aorta can be interrupted. This is an example of an interruption of the aortic arch, where the ascending aorta stops after giving the arch vessel branches. In these patients with arch interruption, the descending thoracic aorta will be fed by the patent ductus arteriosus from the main pulmonary artery. We can notice on this ductal view the continuation of the main pulmonary artery through the ductus arteriosus into the descending thoracic aorta. So in this segmental approach to congenital heart diseases, we define the cardiac chambers in different segments. Start with identification of the visceroatrial situs and cardiac position. Then look at the atrioventricular connections and ventricular morphology. Then move on to ventricular-arterial connections and analysis of the great arteries. And finally look at the extracardiac abnormalities as well.